WPSU is your source for Penn State sports, Penn State research, Penn State community. But we can't do it without your support. Make a contribution today and get a DVD of your favorite Penn State show.
I do some consulting work on American
feeling in the room was
You don't ever say to her that her point is
Chautauqua Institute. Introductory discussion on the ethical
We left.
more of a community.
Before China took back over.
Currently doing in autism.
The American healthcare system is widely acknowledged to be one of the most complex and confusing and the least user-friendly in the world. According to the World Health Organization, the U.S. healthcare system ranks 37th among industrialized nations. For nearly 100 years, this country has debated healthcare reform. What forces shaped our current system, and where does it fall short? What might a more humane system look like? More importantly, how likely are we to see meaningful change in the near future? For insight on this perplexing topic, we talked with Chris Calkins, Director of Outreach Health Initiatives and Instructor of Health Policy and Administration at Penn State. Calkins draws on more than 25 years of experience in healthcare and education to explain the debate and to outline the problems the system will face if things don't change. His perspective is informed by past work in hospitals, with hospital consortia and health systems, and in the insurance industry. Here's our conversation with Chris Calkins. Chris Calkins, welcome to the conversation.
Thank you. It's good to be here.
You say that the American healthcare system is the most complex, irrational, and confusing. Let's start with that first adjective. Why the most complex?
I think part of it is because it's a market-based system, and so what we have in the United States, unlike any other industrialized country in the world, is a combination of public-private models. So there are new entrants to the marketplace all the time, driven by the potential for profit in the health system. So there's actors who come in and out of the healthcare system. Essentially, they're regulated, but the market is driving who intervenes in health on our behalf. Whereas most other industrialized countries in the world, there is a government organization who's really charged in creating and managing a rational delivery system.
Okay, rational. You said irrational and confusing.
Right, right.
Because we have to figure out as consumers how to navigate all of these things?
Absolutely. I think, you know, if we think about our close neighbor Canada or the UK, there are province-wide or local community councils that help to kind of design what assets and resources are available to address human health issues in those populations. We really leave that to the individual in the United States. To some extent, they've got a partnership with the HR office and their employer, if you will. They've got Medicare and Medicaid, so they've got the government on their side if they're covered by those plans. But by and large, it really falls to the individual to figure out how to navigate. In my mind, the central challenge in that is you need to learn how to navigate when you become sick. And that's not really a good time to try and make good decisions about how to move through a complex system.
Part of this is because these other countries that you've mentioned that do have universal health care, they've had national conversations about what they want for their citizens.
Right.
Why has it been so difficult for Americans to have that conversation? We've had it, but it never really leads anywhere.
Right. You know, I think part of it is a disquiet with health and issues around health among the American population. There's some concern, always a default to privacy and individual rights, whereas in many of the other countries in the world, there is much more, I would say, of a social contract expectation with each other than there is in the U.S. And so we do have national conversations around health issues, but they tend to be, I think, around issues, one, that drive cost, or two, that are amenable to intervention, like trying to get people to stop smoking, or seatbelt laws, or helmet laws, and those kind of things, because we see a direct economic impact on the rest of us from other people's behavior. But we haven't really had a conversation outside of the halls of Congress when Medicare was debated and those kind of things about what is the health status of the U.S. population that we want to have, and how do we design the system to deliver that.
And of course, everyone's right now talking furiously about how to redesign the American healthcare system. And in fact, President Obama, in his September 9th speech before a joint session of Congress, said he's not the first president to take up the cause of healthcare reform, but he is determined to be the last. Give us some historical perspective. Literally, for almost a century, presidents and others have tried to move this forward and haven't. What's the history?
Well, I think part of it is in the beginning of the 20th century, as we were moving from agrarian to industrial age, part of what drove that conversation was a rising awareness that workplace safety and actually lack of safety in workplaces was dramatic and was killing a lot of people, essentially. And so you started to get government action around health formed around making workplaces safer as we move through the industrial age. But what began to happen, I think, both with the advent of World War I and then the Depression and then World War II, we had large populations of Americans for whom health and access to health were significant challenges, and a collective sense that we needed to do something about it. We owed the greatest generation, as Tom Brokaw would call them, we owed them a debt as a society. And one of the ways that still continues to impact folks in those populations is access to adequate health care and access that Social Security provides to a living income at the end of life. And those have been the sort of the foundational pieces around which we've talked about health over the last century. More recently, it's clear that the percentage of the government's budget committed to health is growing exponentially compared to other components.
Twice what most other countries spend.
Absolutely. And it is now, the conversation around health is much less about populations that we want to be able to provide dignity and health to, and much more about the economic reality of this is an unsustainable growth rate. We can't as a country afford to have the current system and the way that expenses are driven within it.
Talk, if you would, about the forces, the key challenges that really make this, as many people say, you know, time is of the essence. Right.
I think there are two that truly dominate in my mind. One is the aging of the baby boom generation. So that cohort of people between 1946 and 1964 is about 76 million people. They become eligible for Medicare at 65. So in 15 months from now, January 1, 2011, if you do the math, 10,411 people a day will turn 65 a day. That will happen every day for 20 years straight. That bolus of demand that is represented by the baby boom is rolling towards a system that is facing critical workforce shortages. So demand and supply are critically out of balance at the moment, and they tend to be.
When you say workforce shortages, you mean medical personnel to care for their needs.
Right. So nurses, there's a projection by the U.S. Department of Labor that there will be 300,000 to 500,000 vacant nursing positions over the next decade. We cannot train people fast enough to replace those who are retiring. Nursing is incredibly demanding work, and so people don't stay in it long in direct patient care because the physical and emotional demands of it are very high. The other challenge we have in physician supply is an imbalance towards specialties because of the way they're reimbursed, and an imbalance in distribution. There are whole swaths of Pennsylvania, very specifically, but nationally as well, of rural parts of our country that have little to no access to primary care, no dental care, no mental health services. Each of those things are critical, especially if we just think about those folks who are 65 and older who are rolling into the system.
So let's say we suddenly come to some agreement and agree that the 46 million people who are uninsured are now insured. What does that do in terms of access? We've only solved one part of the problem here.
Absolutely. And I think you need to think about access in two ways, both economic access that insurance provides to people, so effectively lowering the cost of seeking care, and physical access. So if we insured everybody in rural Pennsylvania who was uninsured right now, they still wouldn't have physical access because there are very few providers in those parts of the community. So, you know, initially, what I think we would see if we could wave a magic wand and insure the 46 million people who without it, is we'd have a spike and a sort of
a bump with the tail, you
right, a bump and a long tail. We'd have a kind of flu season, a prolonged flu season impact on the healthcare system. Hospitals would fill up. We'd, I think, kind of churn through this very high occupancy period, but then as people trusted that they would continue to have economic access to health care, we would tail off and people would kind of regress to the mean. They'd go back to normative behavior.
But people who delayed going to the doctors because or the hospital because they didn't have insurance, I'm wondering what the health outcome is for them, because those who are uninsured are more likely to die of a stroke or of a heart attack.
Right.
And to go into the hospital with at a higher stage, you know, stage 3 or 4 cancer rather than stage 1.
Much sicker. There's actually a growing body of evidence in the literature that, in fact, those who are uninsured receive a poorer quality of care. So the Commonwealth Fund and the Kaiser Family Foundation and others have done interesting studies in this. So you're absolutely right. People without insurance delay care seeking until they're sick and absolutely can't delay care seeking anymore. I think the other challenge for us as a system is pharmaceuticals are really highly effective interventions, if you will, for treating illness. But when you put the economics in the equation, many people without insurance lack the economic capacity to be fully compliant with the drug regimen, let's say. So when that's antibiotics, what we're doing, if people stop taking the medicine before the full course is done or dilute it so they can extend it, what we're in fact doing in a public health and epidemiologic sense is creating disease-resistant strains of illness. And because we're doing that in a population that lacks consistent access, they're effectively serving as an incubator. It sounds a little sci-fi to me, but I think there is a risk in my mind that we've created a population, because they lack access, in whom disease changes its shape over time and then exposes the rest of us, right?
Which really raises, I guess, another point for why the fact that my neighbor is uninsured is a concern to me.
Absolutely. I think even if you just think about infectious and communicable diseases, people who don't have ready access to treat both symptom but underlying disease essentially raise the risk for the rest of us all the time. I'm not sure that insuring everybody would get rid of all of that. Infectious disease is, you know, great at mutating, as you know, but it would, at the very least, remove the economic barriers to accessing the system and giving us a better shot at controlling it.
Well, you talked about the importance of pharmaceuticals. On the flip side, though, they're also implicated in a huge number of medical errors.
Right, right. You know, I think part of the challenge for the pharmaceutical industry, if you will, is that when the FDA approves a new drug, there's a timeline set to it, and then it becomes generic, right? So there's a short market opportunity for them to make as much profit as possible on new drugs that have been through sometimes a 20-year research and development pipeline. And so the other thing is the FDA has essentially a limited capacity to evaluate human drug trials. So we test things in a very narrow population, often looks like middle-aged white men, for a defined set of time just to see if there are any adverse outcomes. And then we allow it to be released to the market. But that prescription gets written for all kinds of people that don't look like the population we tested it in.
And not necessarily for the same reason that it was first introduced.
You know, I think one case in point is statins that were are associated with heart disease are now being prescribed to obese kids as young as 8. We have zero evidence of the effect and effectiveness of that drug in a pediatric population, nor do we have evidence of what the systems, organs impact is of putting a kid on statin at 8 years old who might be on it for 20 to 30 years.
I want to move back for a minute because we were talking a little bit about historical perspective and attempts in the past, really over the last century, to move health reform forward. I think of Harry Truman back in the 1940s. When he tried to bring health care reform to the United States, a PR firm came out and said that if you endorse his ideas, you're endorsing socialized medicine.
Right.
You're a commie.
Right.
Why is the socialism argument still a powerful one today?
I think for both historic and political reasons. So socialism and its link to communism in the World War era up through Vietnam and the Korean conflict was a sort of powerful boogeyman and could be leveraged very effectively in the public. And so stakeholders who have a vested interest in the system remaining in the shape it is, they make tremendous profit either when you pay your premium to be insured and they don't have to spend anything on you, or in fact, if they're providers of care, they make profit when you're sick. I think it persists because it's effective. It's a very powerful political tool to oppose government being engaged in and taking over, as opponents would say, the health care of people in the United States. I think most recently of the use of the death panel, boogeyman, if you will, to set up this idea that the government would begin to decide on how much quality your life meant and whether it was worth investing anything in you. And, I think, again, what concerns me most as a person who cares about health is the U.S. healthcare system is confusing and irrational enough without ladling fear on top of people that you're going to go into care seeking and never come out because the government will have some hand in killing you, if you will. That really moves us completely away, and I think that's the point, from actually having a dispassionate conversation about what are the health goals we want to achieve. But
we don't have these same kinds of conversations or angst about socialized law enforcement, right, socialized roads, fire prevention, military, schools, K through 12, for example. Right. Is K through 12 education in some way inherently different than providing health care? Yeah. I think it is in two ways. One, the public good notion of it is, I think we can agree collectively as a society that what's in the best interest of our kids is best for all of us. And K-12 is not only protracted, it's 12 years. But it focuses on children who are hard. When you look into the face of a child, it's hard to say no in any way, shape, or form. And I think collectively don't want to think of ourselves as a society who are comfortable with the idea that we'll deny kids access to education because we know the value of it. Health is different in that it's deeply personal to people to some extent, and I think Americans are not, by and large, good about thinking about death, even though my expectation is that all of us will die at some point. None of us gets out alive.
Right, exactly. But the notion of health and health care is one that we have not, as a society, been good about having a dispassionate and open conversation about what does that mean, what does it look like, and who should have access to it.
You mentioned profit a moment ago, and the Physicians Working Group, which is made up of, I think, 1,700, I hope I'm not misquoting the number, right, of physicians who are working toward healthcare reform. They say there are 4 overriding principles. One is healthcare is a human right, but the fourth one is that there is no place in caregiving for corporate, for-profit caregiving. Talk about for profit. Is that unique to the United States?
It is, by and large. We have a public-private model, so the public plans are Medicare and Medicaid, the VA. Those are all things that are essentially government-run programs, so that's the public side. The unique part of the American healthcare system is that we allow the market, the free market essentially, to determine who gets access to healthcare, what the costs and expenses are within that system. Again, I've spent part of my professional life as a hospital administrator. Each hospital sets their own charge master and then negotiates with insurance companies and other powerful actors from there. So we're determining what we're charging for things. There's, a disconnect to some extent between what it actually costs to deliver that service and what we charge for it, to some extent because we know a certain part of the population we're treating is uninsured, so we're not going to collect any reimbursement from them, so we spread the cost over other people and other services to get to it. I think here's the central challenge, which is we've put your health and illness essentially in opposition to the profit potential of many companies in the system. And, in a market system, companies act like companies are supposed to act, essentially. They're profit-seeking all the time. If they're reporting quarterly profits in the marketplace, they need to hit their target so their stock price goes down. Those are important metrics in the American system. The fact that they're impactful and tied to the health of our population is really the place where I think our system has fallen apart a little bit.
Many say that the proposals that are before Congress focus on insurance company reforms and not systematically at health care reform.
Yeah.
How would you respond to that?
I think that's completely true. I think what most of those health reform proposals, and I think you could think of them rightly as health insurance reform proposals at the moment. There are sort of the kind of placard standard statements in all of the health reform proposals around health insurance practices, like denying coverage to people who have pre-existing conditions or changing their access when they start to use or have health-related expenditures, either ratcheting up their premium or no longer offering, because we have annual enrollment, they no longer will be offered that same plan. So they essentially need to do seeking for a new health insurance plan. They're dropped from coverage. Part of the problem with that is continuity of care is critically important to people, especially with chronic illness. And that cycle of allowing insurance companies to move a big chunk of the population out of their risk pool, if you will, and denying care to people as they become sick breaks up the effectiveness of actually having access to health care. And so those are easy targets politically to aim at. The bigger challenge, I think, within that is that there are about 1,200 insurance companies, health insurance companies in the U.S. In some places, Alabama is the example most recently used. The Blue Cross Blue Shield plan there has 91% of the market share. When anybody has monopoly power, there's no regulation on the prices that they charge because there's no viable alternative in the marketplace. So I think, part of what these proposals are intended to do is to use the market by interjecting the public option as a competitor in those places where monopoly exists. But that option has been, we saw this morning on the front page of the New York Times, the public option is not in the Senate Finance Bill. And I think essentially we're speaking out of both sides of our mouth. We want the market to function, but we don't want competitors. We don't want the market to get more competitive. Insurance companies would say that the government has an unfair advantage because they don't have the marketing and administrative and executive bonus salary structure to support. But again, that gets us talking about the structure of the health insurance market and very far away from talking about the health of our population.
So would you agree we need to expand the conversation, that we need, and President Obama did mention that he'll look at malpractice reform?
Absolutely.
And defensive medicine, which
Right.
probably accounts roughly for 30% of medical expenses.
Right. I mean, I think both the way in which physicians practice and essentially this is called utilization, driving utilization, because I'm ordering tests, because if I don't order that test and something untoward happens, your attorney is likely to point to the fact that I didn't follow well-established medical guidelines, and therefore I'm at risk and I have some burden. We've got hospitals in Pennsylvania for whom malpractice findings are larger than the entire assets. And essentially, what that means is the hospital goes into bankruptcy and effectively closes. I mean, here locally, Phillipsburg Hospital has been open and closed 3 times in the last 5 years. What that really means for that population is 2 things. One, access disappears and travel becomes a key part of accessing health care. But 2, healthcare organizations really serve as economic anchors for their communities. It's hard to recruit new workers to a place if you've got bad schools and no access to healthcare. Why in the world would I move my family there? And so we've put healthcare providers in a situation where they can't be economically viable and effectively written off whole communities because the healthcare, the economic anchor can't survive in that place.
President Obama said, everyone, this is a quote, everyone understands the extraordinary hardships that are placed on the uninsured, who live every day just one accident or illness away from bankruptcy.
Right.
These are not primarily people on welfare. These are middle-class Americans. True? I mean, who are America's uninsured?
Yeah, they tend to be people age 18 to 64, so kids who are no longer covered by their parents' health insurance and at the upper end, not yet eligible for Medicare or public programs. They do tend to be working individuals, and I think President Obama's right. They are middle class by that definition. But if you don't have access to insurance, so let's just take a kind of case in point. I go to the hospital for a 2-day stay, and my hospital bill, let's just say in round numbers, is $10,000. If I have insurance, the insurance company has negotiated with the hospital what percentage of the bill they'll pay and has negotiated that they can't balance bill me for the rest of it. So my portion of that bill is going to be my hospital copay, let's say, which would be $500. If I'm not insured, I'm looking at the entire $10,000. Even
that nobody else pays.
Absolutely. And even middle-class families can absorb $10,000 for 2 days in the hospital into their household budgets.
Now, the insurance companies are saying that all of these proposals on the table will drive insurance companies out of business. You say there's another way to look at that, and that is that these 47 million represent a potential boon for the industry.
Absolutely.
I've never heard that.
Yeah, well, especially if one part of the legislation, the proposed legislation that gets passed is an individual mandate, like Massachusetts has experimented with, so that you have to have health insurance. If we don't have a public option, but we require everybody in the country to have health insurance, the existing health insurance companies now have a new marketplace of 47 to 50 million individuals, many of them of whom, if we do a sliding scale, at the lower end of the economic scale, will have government support to purchase health insurance. It's essentially cash for clunkers in healthcare. I'm going to give you some money to let you have access to the marketplace. The insurance company is going to collect a premium, especially, let's say, if you're an 18 to 64-year-old worker, or let's say you're a 23-year-old man in good health. I'm paying my premium. Especially if I'm a guy, I'm medicine phobic anyway. There's zero cost associated with me except for the administrative part of processing my premium. It's pure profit. And so when we think about who are the uninsured and realize that they are in fact working people and not people who are essentially sitting under a bridge in ill health waiting to have huge expenses come toward the system, that's a boon.
It's a mix of these people, the healthy young guy and the person who, because of a pre-existing condition, couldn't get health insurance.
Right, absolutely, absolutely.
You mentioned Massachusetts, and lots of people say that before we engage in this on a national level, we should baby step. We should look at local examples, and of course that is one. They're now 3 years into their experiment of mandating that everyone be insured at risk of a $1,000 penalty if you're not, and I think it's only 2.5% of Massachusetts residents who are not insured at the moment.
That's right.
But the problem in Massachusetts is they mandated the insurance, but there were no cost controls, and so they're experiencing lots of problems.
Exactly. And I think that's part of the learning that we can expect. You know, I think when Medicare passed in 1965, and we started to see on the government budget dramatic growth in healthcare expenditures, Medicare put cost controls in place, and because they controlled the whole population over 65, they had enough market power to push back on prices. And in fact, you know, Medicare right now, many insurance companies peg their reimbursement rates to what Medicare will reimburse. I don't think it's in fact possible to cover the entire U.S. population without putting cost control measures in place. We talked about this sort of big bump in the long tail.
Meaning people utilizing the services.
Right. That initial expense literally could overwhelm any budget that needed to respond to it, and if to some extent the government budget will always be part of that. The truth is that rolls backwards towards all of us. The fact that I have insurance and you're uninsured doesn't mean that I don't have any expense related to your uninsured status. I'm paying it in higher premiums, I'm paying it in higher prices when I use health care because we're cost shifting around. And estimates range from $1,000 to $1,700 to $2,500 on the cost per American of having this cohort of uninsured people.
What do you think's going to? How do you think this is going to play out?
Yeah, you know, I think we need to think about the political reality and not healthcare in answering that question. I think part of the answer is that I think something will get passed through the Congress because the pressure to get something passed, I think, is growing among the American population. I think the challenge is half measures don't respond to both the demographic and workforce shortages we talked about, and in fact reinforce parts of the system that we already know to be negative.
But there are global comparisons which could be helpful, but of course we can't superimpose on the United States what other countries have done, and in fact in Asia, Japan and Taiwan have very different universal health care plans. In Europe, Germany, France, Britain, they're all very, very different. But what can we learn from them? And is there one system that ours might most look like?
Yeah, I think what we can learn from them, Japan is a good example, France and the UK and Canada are others, is especially in Japan, the model is built around primary care and prevention. So people go to the doctor a lot in Japan, but there's both, and I think, you know, what's important to understand is there's a cultural norm in Japan. It's why when there's infectious disease season, you see almost everybody wearing a mask on the public subway in Japan. That would scare the heck out of people on the DC Metro, I think. But there's this social expectation that we're responsible to and for each other. So in that system, people go to the doctor not only when they're sick, but to make sure that they're staying healthy. And you know, I think one of the things that we've gotten away from in the United States that it's sad to have taken out of the system is the social and emotional support component of visiting a healthcare provider. Right now, a primary care provider who's running a physician office has 2 clinic rooms, and they need to see 3 people per hour per clinic room.
In each one?
In each one. So they're looking at 8 to 10 minutes per patient just to make the economics work. There really isn't any room in that for the discovery of the underlying concern that comes from medical symptoms. All we can do is sort of diagnose and treat and respond. It's, I think, go ahead.
Well, we're doing it so quickly, it might be why we're ordering tests. Absolutely.
Well, part of it is that if I can't immediately diagnose you, because I've only got 8 minutes to talk to you, I'm going to look to my supports in the system. I'm going to order a diagnostic lab test, I'm going to order a radiology test, and I'm going to string out that process so I essentially have more time to think about what's really underlying. If I had a half an hour, which seems laughable right now, but if I had a half an hour, I could get you through the first 5 minutes where you're talking about nothing until we get to the real thing that you're there for, and I would have time to sort of tease that apart and say, is your chest pain related to stress in your family because your spouse has been laid off and the economics of your household have changed? That's a very different need than chest pain. And in Japan, I would argue, they have time and they have a system built on that sort of visit model that enables them to discern these things.
Well, speaking of visits, in Japan, the average citizen seeks a doctor 16 times versus, I think, 4.3 in the United States, and yet they do it. We're talking about a country that does have lots of economic problems. Yes. I don't want to overshadow that, but they do that at 8% of gross domestic product versus 17.8% or almost 18% of gross domestic product here in the U.S.
Right. Well, and part of it, again, too, is that the way that physicians are reimbursed in Japan is very different than the way they're reimbursed in the U.S. And there is a government sort of expectation that we're going to create a health system. So there's cost control within it. You know, in the U.S., for example, if you, the other thing in Japan is they support medical education for medical students. So their physicians are not graduating with $250,000 in debt, as ours are. So if I go to medical school and I want to be a pediatrician, what I look at is the average salary of $135,000 a year coming out of school compared to $250,000 in debt. I'm carrying a mortgage into my first job. If I stay in school a few more years in residency, I can become a neurosurgeon and make $750,000 a year. You know, by and large, people who go to medical school are smart. They can make these economic equations, and we end up with people in high-paying specialties while we've got a crying shortage of primary care providers in the entire country.
How do we change that?
You know, I think there are a couple of things that people have tried around the world that make good sense to me. One is, in fact, reinvesting in medical education, I think both for nurses and for physicians.
Forgiveness programs.
Right.
You go to school, you become a physician, you serve in a particular area, and you have no school payment. Right.
Right. So, and that's a model that is a win-win for many people, especially if where we're placing people is areas of underservice. So their debt is forgiven over time. Therefore, their salary is actually more of a living wage, and they're not having all of this debt service. But we're meeting a shortage, a supply shortage issue as part of that process. You know, I think the other thing is having loan forgiveness attracts more people to medicine who are attracted to it out of altruism and a desire to do good and actually deliver good patient care. Right now, I think you need an MBA as well as an MD to survive in the U.S. healthcare system because physician practices are adding 1, 2, 3 full-time people just to negotiate with insurance companies. And you're burning up an awful lot of payroll just for the administrative process. So if we can change part of that equation as well, I think it lets us enable physicians and nurses to have more time in direct patient care, which by and large, I think, you know, the U.S. system is viewed as the envy of the world. That's true for that narrow cohort of people who have good economic access to the system and who have the capacity to go to the physician who actually has time to care for them.
We're often spending more money using more technology, more invasion, And the outcome, according to a Dartmouth study, is that the outcome really isn't any better for all the money that's spent in those last 2 years, oftentimes.
That's right. And I think what we're trading off there is quantity of days versus quality of days. We're spending, and to be, I was going to say to be fair, but I think just to understand it, you know, if I'm a hospital administrator, I don't want you to die in my facility. I don't want your mortality statistic to be reflected upon me.
Your books.
Exactly. I want to move you away from me if I can. And so I'm doing everything I can technologically to keep you alive while you're laying in my inpatient bed and on my service.
And that's driven because of profits as well.
It's not only driven because of profits, it's also driven around concerns, defensive medicine, and around concerns about malpractice. I think the truth is, I've worked in academic medical centers, is that we're training physicians in that model too. And if you look at a person who starts medical school in their first year versus the person you graduate at the end of residency, the business and economic realities have changed the sort of core of why they're in it. Many of them sort of lose the passionate connection to care along the way because they're buffeted by the economic realities of it. The other thing is that we train physicians to do everything in their power to help. Sometimes the thing that's the most help is to tell somebody the plain truth, that there's nothing technologically or from a medicine perspective that we can do. Let's now talk about how do you want your life to end in a way that preserves your dignity, gives you time outside of this place. Nobody wants to die in a hospital. It's it's not designed to be a humanistic place, if you will. It's a clinical environment. So we've removed the capacity to some extent because of the economics and the legal nature of the system from enabling us to have those conversations.
So the conversation you need is what constitutes a good death.
Absolutely.
This brings me to rationing, and if you look at Britain's National Health Service, everyone, not everything, is covered. For instance, in the U.S., it would be routine for someone a male over 50 to get a PSA test.
Right.
They don't do that in Britain.
Right.
Some would look at that as rationing, and you say that in some form or other, every nation, even those with universal single-payer programs, ration.
Right.
How do we do it here?
Well, we ration here first by denying a huge segment of the population economic access to the system. They're uninsured. They don't really have access to the system. The other is the way that we ration it. So let's talk, for example, about diabetics and endocrinologists, so people who deal with folks with metabolic disease and diabetes. Diabetes is a growing problem in the U.S. population. The American Society of Endocrinologists says there are 4,000 board-certified endocrinologists in the U.S. There are 44 million people with diabetes at the moment. That's 11,000 each. If all you did every day was to see diabetics as an endocrinologist, you'd have to see 5 patients an hour for full-time, nonstop. So right now, if you lived in State College, Pennsylvania, and you called up for an endocrinology appointment, the rationing happens in that appointment is going to be available to you 3, 6, 9 months out. It doesn't mean that your diabetes goes away for those 6 months. It means you don't have access to the system. That is effectively rationing by physical access barrier as well as economic access barrier.
Prevention could play an enormous role in reducing the numbers of type 2 diabetes in this country.
Absolutely.
You use an interesting, the 3-4-50 principle. What is that?
Well, it's actually, there's an organization called 3-4-50 that notes that there are 3 factors that lead to 4 diseases that account for 50% of the deaths on the planet every year. And those are tobacco use, improper nutrition, and a lack of physical activity. And they lead to heart disease, respiratory disease, diabetes, and cancers, which account for half of the deaths every
And all the
year.
money we're spending.
Absolutely.
A lot of it.
When you go back to the beginning then and you look at tobacco use, nutrition, proper nutrition, and physical exercise, no system in the world can force you to change your behavior in those things. Those are all individual behavior choices that need to be made to stop smoking or using smokeless tobacco, to eat a better diet, and to exercise more. Those are all personal investments you can make that will keep you out of this system that we've already talked about extensively, is fractious and irrational and complex. And yet, one, we're loath to mandate to anybody that they actually invest in their own health by changing their behavior. But, you know, as a population, we're surrounded by marketing that encourages us to sit on the couch and watch television, to eat highly processed foods, and to smoke or chew tobacco.
So another mismatch, you know, the messages that we're getting, you know, supersize me. But prevention, you know, as it is, we're only spending 5 cents of every dollar on prevention. Right. When HMOs came on the scene, and HMOs were supposed to dramatically change the healthcare landscape, what happened with the prevention component, and why didn't HMOs live up to their promise? Yeah,
to some extent, I think because HMOs were still an insurance product and disconnected to some extent from the delivery mechanisms. So if we think about places like Geisinger or Intermountain Healthcare or other integrated delivery systems, that's a model that essentially has an economic return for investment in health and prevention. So if we just look at Geisinger, for example, they have a health insurance product, they own hospitals, and they employ physicians. The insurance piece of that integrated delivery system has a vested interest in keeping you healthy, and they have the capacity to change access, physical access, so that you can get access to more preventive care, diagnostic testing, so that we can catch diseases early and intervene on them at a time when we've got more effectiveness to return you to full health than we might otherwise have.
President Obama and others talk a lot about Intermountain Service and Geisinger. Are these programs that can be replicated?
Yeah, I think they can, and in fact, I think they are. There's quite a bit of regulatory structure that keeps healthcare organizations essentially from talking to each other, so they can't collude in the marketplace. But you know, where we started with the demographics and the workforce shortages, I think increasingly hospitals and physicians are aligning with each other. So the delivery capacity is starting to band together so that they have some economies of scale and some market power. What, you know, the disconnect is from the providers and the insurance product, so that we get the kind of vested interest in health promotion and prevention at the moment. I think that the market reality of what's coming is going to push the development of more integrated systems, because it makes economic sense across the country. You know, what we would need is state and federal legislation to sort of allow that to happen right now. You know, there's concerns, part of what keeps it from happening is concerns that any one provider or system would have a monopoly, and therefore prices would go up again. I think, you know, part of what we need to ask is, if the health status of a population improved dramatically, would we worry so much about the actual marginal cost of providing that going up? And in fact, there are, I think, good examples in the literature of true cost savings, but they take a longer timeline when you do invest heavily in health and health promotion. You mentioned a moment ago that we often talk about the United States as having the healthcare system that's the envy of the world, and for some people it truly is, but according to WHO, the World Health Organization, we actually rank 37th. France ranks #1. What kinds of information goes into that? Why do we rank so poorly? you know, part of the way that the World Health Organization came to that ranking, which they did in the year 2000 and haven't actually done since because it's very complicated to work through that, includes really three factors. How does a country invest in access? So do they provide financial support for people who are training in medicine and nursing? Do they try to have a rational system of distribution of healthcare providers? So that's the access piece. The metric that they look at is disability adjusted life expectancy. So how does the system respond to, in fact, allowing people to live healthier longer? And the third piece, and part of the reason that the United States falls well down the list, is that they look at the economic rationality and fairness, the balance of the economic burden that falls on individual households. And in France and in Italy, who's number 2, the government bears a great deal of that expense. The marginal cost to a household of being sick is very small compared to the United States. And that's really the thing, the factor in the equation that pushes us way down the list.
In his book, T.R. Reid talks about better, cheaper, fairer, and that really seems to be what we're trying to get at in this system is fair. The Pennsylvania Department of Health issued its first State Health Improvement Plan, or SHIP, back in 1999. You are involved right now in developing that plan for 2011 through 2015. Tell us something about it.
So the State Health Improvement Plan is actually a requirement of the Department of Health. Each state needs to have one. But it's really a collection of 62 local partnerships, SHIP partnerships in the Commonwealth. And part of the process we're going through now, historically these documents have been collections of incidence data and to some extent, you know, a kind of dashboard of what's the impact of cancer in your community, what's the impact of heart disease in your community. What happens is local communities, one, don't really have the capacity to wade through all of that data and make sense of it, and two, it is left with sort of, okay, so what can we do about this kind of question at the end? The way that we're writing the current State Health Improvement Plan is to actually reference data and incidence data, but to provide to communities action steps for how to intervene on health issues that matter. So if we look at things like diabetes or childhood obesity, what are the best practices that we can find in the literature, and looking across the country at communities that are trying to address that for the most effective ways to get at the outcome that we want to.
And are people obligated to do what your recommendations are?
They are not, actually. There isn't any requirement that communities actually take up any of these things, but there is, as we've described, a sort of local community vested interest in improving the health of your population for not only economic reasons, but for the impact on the education system and those things that matter locally. I think the good news is actually in the SHIP partnerships that there are people on the ground who care deeply about these issues. What we're going to try and do in the next State Health Improvement Plan is give them effective tools to not only intervene, but to evaluate the effectiveness and learn how to do what they do better over time.
You care deeply about these things, and I'm wondering just how optimistic are you that finally, after nearly a century, that we will pass meaningful healthcare reform?
Probably less optimistic than I'd like to be. You know, in my head, Patty, what I'd like it to be is sort of a 50-50 hope. My guess is it's more like 35%, because the key word in your statement there is meaningful. We are disconnected as a population and as a government, even in undertaking this debate, from actually talking about the health of our population. What we're tinkering with right now is how is the health system structured and how does it function? And you know, you can fix a machine so it runs more efficiently, but if it doesn't actually lead to the outcome that you want it to, you're tinkering at the edges. And I'm afraid, frankly, that that's what we're doing with this legislation, is we're trying to make a fractious system a little bit better, a little bit more efficient, a little bit more accessible, but that in and of itself isn't really ever going to get us to really meaningfully impacting the health of people.
Well, then I have to end with, I mean, our current model, everyone would agree, is unsustainable. What are the consequences if we don't do something? And some say what we need to do is not incremental, it's huge, big change now, but that doesn't sound like it's coming. So what are the consequences?
You know, I think, and I'm loath to scare people, but I think honestly the true consequences if we do nothing, especially as this baby boom cohort ages into the system, if you will, is that we will spend an increasing proportion of our federal budget on health and therefore have less available to meet any unknown needs that arise right now, everything from war to helping repair the economy. I think honestly what it will mean is that we're about to look at a generation with higher mortality rates than are otherwise achievable, just because there isn't access. The things that are even amenable to health care, people can't get access to, and they're going to die sooner. I think the other thing that is a real consequence is that we've essentially set up an intergenerational conflict, and we are transferring to a younger population both the economic burden of these things, but also the emotional burden. You know, nobody becomes a young person in the United States without being attached to a lineage, a family that's got older family members who will engage the healthcare system. And we've set up this dynamic where the emotional impact on them is as a family of increased mortality is dramatic, and the financial implications of that are equally dramatic. You know, it's what many working uninsured families face every day is literally sitting around their kitchen table with coins and dollars sitting there and having to make decisions about food, housing, transportation, school, and health, and those kind of things. We have a population that's unprepared to really have that rational economic decision, but we're about to force them to make it. Do I pay to keep somebody alive who's at an older part of my family versus feeding the younger members of my family? You know, for me as a person not only who cares about social justice but about public health, I would love for us to find a way to keep people from having to go through that equation every day. And right now we've got 1 out of 6 people in the U.S. are in fact making those decisions every day.
And we're going to have to leave it there. Chris Calkins, thank you so much for talking with us.
Thank you.
We hope you enjoyed our conversation with Chris Calkins. If you'd like to learn more about the American healthcare system or proposed plans for reform, or to view additional clips from today's interview, visit us online at conversations.psu.edu. I'm Patty Satalia. Thanks for joining us. We hope to see you for our next Conversation from Penn State.
Production funding provided in part by the Corporation for Public Broadcasting and by viewers like you. Thank you. This has been a production of WPSU. A copy of the program you've just seen can be purchased through Penn State Media Sales at mediasales.psu.edu or by calling 800-770-2111.